Hey guys, my name's Austin. I'm a third-year medical student at Western University who's currently rotating with Dr. Ben-Zur. And today I'm going to go through with you guys how to approach an EKG when you're first given one. And one of the most important things to know when you're about to interpret an EKG is to do it methodically. And different doctors have different ways of approaching it, but I will go through with you today the most common way and the way Dr. Ben-Zur likes to go through it. So to start, it's always good to look at the rate. And to do so, there's two main methods of doing this. One is to count how many QRS peaks there are in the strip. So we have 1, 2, 3, 4, 5, 6, 7, 8. 8 QRS peaks. Being that this is a 10-second strip, you'll multiply that number of QRS peaks by 6. So 8 peaks times 6, 48. So the heart rate is 48, so it's looking like this patient is suffering from bradycardia. The second way is to count the number of big boxes in between two QRS peaks. So I like to do this one. I like to find a QRS peak that lines up with one of the vertical lines to make it easier on myself. So we have one big box, which is 300, then 150, then 100, then 75, then 60, and then 50. So based on the big box rule, being that we have 1, 2, 3, 4, 5, 6 big boxes, that correlates to about 50 BPM. So it's about the same, 48 from the first method, 50 from the second. So once again, it's looking like the patient's having bradycardia. The next step is to look at the rhythm. And to do that, you will look at the P waves. So I like to do that by looking at lead 2, which is right here, the longest strip we have right here. And first I like to see if there's a P wave before every QRS, and it looks like P wave, P wave, P wave. It does look like we have a P wave before every QRS, and the interval, the PR interval, does seem to be regular between all of these. Therefore, we know that we have sinus rhythm, or normal sinus rhythm. The next step would be to look at the axis, and to do that, this is a helpful chart that I kind of memorize and have in my head all the time when I'm approaching an EKG. So to look at the axis, or to determine the axis, you want to mainly focus on lead 1 and AVF. So here that would be lead 1 and AVF right there. Okay, and so what you do is you focus on the QRS. So if you have a normal axis, both the QRS in lead 1 and AVF will be up or positive, like this. And actually that's what we have in this EKG here. You can see positive QRS in lead 1 and positive QRS in AVF. So this will be a normal axis. If, however, you had positive in lead 1 and negative in AVF, that would be a left axis deviation. And then if you had the opposite of that, so if you had a negative QRS in lead 1, but a positive QRS in AVF, that would be a right axis deviation. Lastly, if they're both negative, so opposite of normal, that would be an extreme left or right deviation. And to determine whether it's left or right, that is a little bit more complicated, and I will not get into that in this video, but you can look that up if you ever are approached with one of these cases of an extreme left or right. So yeah, that's how you'll determine the axis. And in this case, like I said, we have a normal axis. And then next, you can go back to actually the P waves and see if you have any abnormalities within the P wave itself. So two things that it's always good to look for is if you have P pulmonale or P mitrale. So P. pulmonale is a sign of right atrial enlargement. And basically, it'll be when you have a P wave that has a higher amplitude than normal, which is usually, you'll find it greater than or equal to about three small boxes. Like I said, indicating right atrial enlargement. In this case, we do not have a high amplitude P wave. Another thing that's good to look for is P mitrale. And P mitrale is a sign of left atrial enlargement. And for that, you'll find a P wave that's usually wider than normal. And so normal is about 0.08 to 0.1 seconds. Okay, so that'll be less than 3 small boxes wide. So if you have a P wave that's more than 3 small boxes wide, then that would be a sign of P mitrale. And in this case, the width is about 2 small boxes. So once again, these P waves are within normal limits. Then next, you can look at your Q waves in more depth. Or sorry, your QRS complexes in more depth. And the normal width of a QRS is 0.06 to 0.10. So basically that'll be less than 3 small boxes. So about 2.5 small boxes is the maximum limit. In this case, it's about 2, maybe a little less than 2. And so yeah, QRS waves are not widened and are within normal limits. And if you did have wide QRS waves, that would be a sign of possible left or right bundle branch block, which we will talk about in another video. So once we've done that, we can now look more in depth at the QRS complexes for what we call Q waves. And basically Q waves are going to be the first wave in the QRS complex. So if you see here, we have the P wave, which we've been discussing. Then the first dip will be your Q, then R, S, and then we'll get into this later, the T and the U wave. So, but we're focusing on this. If you notice Q waves, prominent Q waves, that could be a sign of an MI or an old MI. So in this case, I do see some Q waves here in 2, 3, AVF. And also, yeah, there are some Q waves seen also. Let's see here. Yeah, 2, 3, and AVF are the leads that I find Q waves in. So that could be an indication that this patient has also an MI. So next, we would look at the ST segment. And so ST segment is going to be the right here. So here's your S wave, here's your T wave. It's going to be the interval between that, right there, the ST segment. And so in this case, when you're looking at the ST segments, I notice right here in 2, 3, and AVF, there's elevation of the ST segments there, if you notice, 2, 3, and AVF. And also a little bit of elevation in V1. And we have then depression in V2, V3, V4. Yeah, V2, 3, and 4, we have some slight depression. And also in lead 1. So elevated ST segment is indicative of MI, which would go along with the Q waves that we see in those leads as well. So 2, 3, and AVF is going to be correspondent to an inferior wall MI, which is supplied by the right coronary artery. And then the elevation in V1 could be due to more of an interseptal MI supplied by the LAD, our left anterior descending artery, coronary artery. And so now that we've done that, we can look for T-wave abnormalities. And this strip does not have any T-wave abnormalities, but I will show you what we were looking at before. So here is the T wave, which is normal. And then here we could have a U wave, which is a small peak after the T wave. Usually you will not have a U wave in a normal EKG, but a U wave can be indicative of hypokalemia. So that's something to remember. Also, if you have a higher amplitude T wave, a high peak T wave, that could be a sign of hyperkalemia. So T wave abnormalities and U wave abnormalities are important for potassium electrolyte abnormalities. And so now that we've done that, we can check how we've done. So as you can see, sinus bradycardia, which we did find because the heart rate was 50 or 48, depending on which method we used. And then also ST and T wave abnormalities suggesting myocardial injury. And once again, we found that in leads 2, 3, and AVF, indicative of an inferior wall MI, and also T wave abnormalities in V1 elevation possible, anterior wall, anterior septal, and then the V2, 3, and 4 could be due to ischemia, as indicated by the depressions of the ST segments here, here, and here. So yes, this is once again an EKG, which probably very common in our medical careers, MI and bradycardia, and this is just a systematic approach to interpreting this EKG. So hope it helped, and good luck.